Thank you very much. Thank you. There. Thank you very much for those of you left. It's been a long day, and it's going to be a heavy dessert. I apologize on behalf. But it's a very interesting topic and a topic that's dear to my heart. My name is Alexander Omel. I am a medical doctor, specialized in anesthesia and intensive care. But the last 10 years, I've used also on the side researching and getting to know something about metabolic health as well. Someone told me once that a good presentation starts with a catchy and provocative title. So that's why I came up with this title, The Illusion of Type 2 Diabetes. And that might trigger some people, but stay with me. So, oh, sorry, that was too, okay, thank you very much. So now I lured myself into a corner, and now I have to convince you that the diagnosis of type 2 diabetes actually is an illusion. And I gave myself 10 minutes to try and prove that the centralized paradigm around type 2 diabetes is wrong, or at least incomplete. In the medical world, we like to diagnose. A lot of diagnosis is often an on-off switch. Either it's there or it's not there. So this is just a picture, this is 2 X-rays, one with an X-ray of a pelvis and 2 hips, one with a broken hip and one with no broken hip. And since this is not an orthopedic lecture, I'll just show you. So we have a fracture on the top one, on the right, and no fracture on the bottom. So it's either there or it's not there. This is a CT scan of the brain. One CT scan is of a healthy brain. The other CT scan is with a very aggressive brain cancer called glioblastoma. And since, again, this is not a radiology TED Talk, I'll just show you, maybe you saw it before. The one on the right has a glioblastoma, an aggressive brain cancer. It's there, at least on CT. The other one is not. So sort of an on-off switch. So, but what about type 2 diabetes? To diagnose something, we need to be able to define the disease. So what is type 2 diabetes? Well, type 2 diabetes is a form of metabolic malfunction. Metabolic malfunction is, as I write here, any impairment in the body's ability to generate, store, and/or utilize energy efficiently at a cellular, tissue, or systemic level. When it comes to type 2 diabetes, it's the carbohydrate metabolism which is broken. So the type 2 diabetes, or so-called type 2 diabetes, is actually a carbohydrate metabolism malfunction. But is carbohydrate metabolism malfunction an on-off switch? Is it there or it's not there? If we ask the centralized paradigm around this, they say it's either there or not. Before 2010, we diagnosed so-called type 2 diabetes with something called an OGTT, oral glucose tolerance test. I'll get back to what that is, or a fasting blood glucose. The HbA1c, you know, the one we get at the physician doctor, telling us something about our blood glucose the past 3 months. But that was not relevant before 2010. Then came 2010, 11, and in Denmark, 2012. A lot of clever people looked at a lot of epidemiological studies, and they found that as HbA1c increases, so does your risk of a lot of different ailments. And something happens at 48. The risk of especially diabetic retinopathy, that's diabetes in the eye, or the blood vessels in the eye that go crazy and burst, that drastically increases. For me, that's sort of the same as telling there is something wrong with your car the moment your engine catches fire. So could we have looked at that before the engine catched fire? But it was a consensus decision. It was an arbitrary cutoff. They said 48, and on the other side of 48, we call that now type 2 diabetes. They even define a pre-diabetic range. Not a range about, when you're in this area, you're in an increased risk of XYZ. You are an increased risk of type 2 diabetes. So a pre-diabetic range is just, well, you are in an increased risk of your engine catching fire. So according to the centralized paradigm, type 2 diabetes is sort of an on-off switch. If you have an HbA1c under 48, you don't have it. If it's over 48, you have it. I've seen a lot of patients in my private practice where they say, oh, my doctor tells me I have an HbA1c of 44, so I'll just come back next year and get a new one. Or an HbA1c of 47. Oh, I don't have type 2 diabetes, so I'm all okay. I'll get back next year. Then I get another HbA1c. Well, of course, that is utter nonsense. Those types of cutoff values do not exist in nature at all. This is the current model of the carbohydrate metabolism malfunction. And when I say this, carbohydrate metabolism malfunction, yeah, that's what we call type 2 diabetes. So this is the crude model where we sort of have a diabetic range, that's the engine catching fire. Then we have the yellow range, that's your engine almost catching fire. And then below 42, we don't have a language to sort of tell, well, is that optimal? So at what point are you in increased risk of your engine catching fire? If you ask, if you ask the centralized paradigm, they actually have nothing to say about this. So we can do better than this, I think. And why does it matter? It matters because, a diagnosis in itself is not what we are afraid of. So an HbA1c of 47 is not relevant at all for us as human beings. The thing that we are worried about are the consequences of that diagnosis. So an HbA1c of 47, I don't care. But what I do care about is what does that mean for my health? So what does that mean for my risk of developing all the comorbidities that we see with people with type 2 and also type 1 diabetes, actually. Oh, sorry. So at what point does carbohydrate metabolism malfunction actually influence your life? That's the important question. A little hint, it often starts decades. Yeah, that's decades. That's 10, 20 years before you get the quote-unquote type 2 diabetes diagnosis and an HbA1c of 47. That's the engine catching fire. Below that is a mechanism of insulin resistance and hyperinsulinemia. Yeah? That can precede the type 2 diabetes diagnosis with 10 or 20 years. Yes. But then, why is that important, you may ask? Well, we know that independent of blood glucose levels, hyperinsulinemia, too much insulin floating around in your bloodstream, is a problem. It's connected asocially, and some of these also causally, to hypertension, to non-alcoholic fatty liver disease, to depression, to cancer, to gout, acne. And actually 50% of the people with a first-time myocardial infarction have only pre-diabetes or normal glycemia, but they have extensive hyperinsulinemia. So that was 10 minutes to sort of give you an idea about that the centralized idea around type 2 diabetes is wrong. And as I said before, or at least it's incomplete. So how can we do better? Can we, with other tools, maybe diagnose the metabolic malfunction when it actually occurs years before the type 2 diabetes diagnosis? And that's a yes. Metabolism doesn't function in dichotomy. It's not on-off. Everything in nature is actually not on-off. It's a continuum. And so is our metabolism. It's a metabolic continuum. This is a very crude continuum. This is actually not a continuum at all. It's just optimal, and then sort of maybe not optimal, maybe a little type 2 diabetes, and then full-blown type 2 diabetes. So we must be able to do better than this, or divide it into more categories, at least. To help us with that, we need the work of this kind-looking man. May he rest in peace, Dr. Joseph Kraft. He was the chairman of the Department of Clinical Pathology at the St. Joseph Hospital in Illinois. And for me, if you want to talk about type 2 diabetes or insulin resistance, like if you don't know Joseph Crafts, it would be like being a Christian who doesn't know who Jesus is. This man is everything when it comes to the foundation of metabolic health, at least in my opinion. So he made some tremendous work for 30 years at the St. Joseph Hospital. He made almost 15,000 oral glucose tolerance tests. And what is that? It's simple. It's you measure a fasting blood glucose, then you drink a bunch of glucose, usually 75 grams, and then you measure your glucose response after 2 hours. That's it. Yeah, that's an oral glucose tolerance test. So when I say that OGTT, I will call it from now on, that's what I mean. But he did it with insulin assays. So he measured, like, how does the body react to the hyperglycemia induced by drinking glucose? And investigated the relationship between the glucose rise and the insulin response. And before this point in time, we didn't have a clue. Unfortunately, a lot of his work has been forgotten, until today, of course. So we have 3 categories of OGTT, these oral glucose tolerance tests. It could either be normal, depending on the glucose values. It could be impaired, sort of pre-diabetic. And it could be full-blown type 2 diabetes. Regarding the insulin responses, he had 3 categories. A normal insulin response, which is called euinsulinemia, which is just a fancy word. Elevated insulin levels, or what we call hyperinsulinemia, and the other side of that coin, insulin resistance. And then you had a third category, which is low insulin levels, hypoinsulinemia. We'll come back to what that means. So, some heavy slides, I know, bear with me. I'll guide you to the numbers that you need to be aware of. So, one of the things that he investigated was the relationship between fasting blood glucose and an OGTT. This is just over here. Over here. Oh, you can't see that at all, can you? No, it doesn't matter. It's in milligrams per deciliter for some of you if you're not from Denmark, or other. In Denmark, we use millimoles per liter. But the interesting thing is that over here in the red square, almost 40% of people with a diabetes diagnosis with an OGTT, so they got an OGTT, they got diabetes results, they had normal fasting blood glucose. That's quite interesting. So you can have a normal fasting blood glucose and be raging diabetic. He also investigated the relationship between fasting insulin and OGTT. And that's also very interesting, actually. First, he defined the normal distribution from 0 to 30. Not what's optimal, but the normal distribution. Over 30, he defined at hyperinsulinemia or type 2 diabetes. So if you had an insulin level fasting over 30, type 2 diabetes. But again, what's very interesting here is that 84% of the people with an OGTT, which showed they had type 2 diabetes, had actually quite low or normal insulin levels. And strikingly, 33% of people with type 2 diabetes on an OGTT had strikingly normal fasting insulin levels, which means that you can't use a fasting insulin to tell if you got type 2 diabetes. I know this is heavy stuff. I know it's late in the day. Bear with me. So he defined these insulin responses. And there's a lot of numbers and so on. Just know that the black squares are the insulin response. The first one at time 0 is just the normal fasting insulin. That's the Kraft type 1. Or this is what defines a normal insulin response. The peak should be at half an hour and 1 hour after you drank some glucose. The sum of hour 2 plus 3 should be under 60. It doesn't matter really. Under 60 IEs per mils. And this pattern he called euinsulinemia, which means normal insulin. Only an OGTT with a normal glucose tolerance test with euinsulinemia is what we call metabolically healthy. The thing is, 22% of people with a normal glucose tolerance test presented with normal insulin levels. And again, we must remind ourselves, why is this relevant? I'll get back to that in a moment. Because these are the three other types of insulin responses. This is hyperinsulinemia, too much insulin in the body. Kraft defined three types: more, even more, and fuck's sake, a lot of insulin. Yes? So the thing is that, you know, the black squares is the normal insulin responses, and the line is the hyperinsulinemic responses. Again, the funny thing is, look at the NGT, the normal glucose tolerance tests. 44% of people with normal glucose tolerance test had Kraft type 2, which is hyperinsulinemia, which means they are at risk. 24% of people with normal glucose tolerance had Kraft type 3. And even 6% of people with the normal glucose tolerance test had elevated fasting insulin levels and a huge insulin response to that oral glucose tolerance test. And this matters. Kraft type 5 is the hyperinsulinemia, which is also relevant. That means creating too low insulin. And actually, 8% of people with an oral glucose tolerance test which showed they had type 2 diabetes actually had a hypoinsulinemic response, which means either one of two things. Their beta cells which produce insulin is very tired, or they are actually misdiagnosed type 2 diabetics, and they're actually type 1s. So a bird's eye view, an oral glucose tolerance test, a normal oral, glucose tolerance test does not mean euinsulinemia. And 75% almost of the people with this test, a normal test, had hyperinsulinemia. That's striking for me, at least. So with that in mind, this current model of carbohydrate metabolism malfunction sort of falls to the ground. Like, where is all this data in how we arrange metabolic dysfunction today? And it's not there. So, but can we use that information to create something that's better than this? And again, in my view, we can. We can learn from other places in the medical science. Actually, we are quite good at grading sort of the progress of a disease like kidney disease. Like, we have grade 1, grade 2, grade 3, grade 4 in cancer, stage 1, stage 2, stage 3, stage 4, depending on how aggressive it is. This is just my take on how we could improve our diagnostics of metabolic malfunction, and we could catch it years before that silly HbA1c only blood test. It's with an x-axis and a y-axis. On the x-axis, we have the Kraft type. We know those at this point, 1, 2, 3, 4, and the 5 over there. And then we have a CGM score. And I use the CGM score because I don't know if you know what a CGM is. A continuous glucose monitor is those that sit on the arm. Joseph Kraft didn't have those technologies back then. He could only measure blood glucose point of care. So 1 and 2 measurements. With CGM, we can see so much more about how the glucose behaves when it enters the body. So that's why I use that. So we could use and actually see, you see here, there's a huge area where you're sort of normal and where your own doctor wouldn't put you in a high-risk group. In this, there are 3 dots where you are in a low-risk category of developing the comorbidities associated with elevated blood glucose, high glucose variability, and high insulin levels. These things are not to be kidding with. Yes? So, this could be a glimpse into the future of how to better diagnose metabolic malfunction. And don't let your doctor tell you that an HbA1c of 40 or 42 or 39 or 47 is okay, and just waiting for you to just waiting for your engine to catch fire, and then we can talk about treatment of type 2 diabetes, but then starts just pouring drugs down your neck. Yeah, but that's a whole nother lecture. So we can do better, and I think we should. The data is there. Joseph Kraft's amazing work for 30 years helped us understand this. So if you want, if you want to know a little bit more about me, I'm sort of I have an Instagram account where I sort of challenge a lot of the main mainstream dogmas of centralized medicine, then you can go visit me there. I also have my own website, PrimeLife, where you can read a little bit more about me and how I think, and also book me for lectures and private consults. So I know it's been a very long day, and thank you so much for listening to this very heavy lecture. I know, but I hope you got something out of it. So thank you very much for that. And thank you very much for coming to Health Week. It's been an amazing weekend. We couldn't do it without you. So I hope really that you had a lovely weekend and learned a lot from all these amazing guys that's been here.